Welcome everyone, and thank you for attending this Connect and Learn session organised by Boost, which is the North East and North Cumbria Learning and Improvement Community. My name is Ashley Eaton and I'm from Boost, and today we are joined by Sue Wallis, who is the Senior Project Manager for the Hospital at Home programme, part of the British Red Cross, and Louise Hedley, who's Health Operations Manager, also from the British Red Cross. And this session is going to explore some recent research by the British Red Cross into how health inequalities can be addressed in hospital at home services and the lessons learned from the hospital at home service partnership between North Cumbria Integrated Care NHS Foundation Trust and the British Red Cross, which was funded by the North East and North Cumbria Integrated Care Board. If you could click the next slide for me, Sue, that would be great. So these sessions are a series of online learning events planned with the purpose of sharing and spreading improvement work across the North East and North Cumbria health and care system. Each has a different focus. So the Connect and Learns are more than just information sharing. They're an opportunity for you to connect with like-minded colleagues around a specific topic to generate ideas and look to take forward improvements in your own work, team or service. And next slide, please, Sue. So before we kick off, just some very quick protocols. If you could mute yourself when not speaking, post any questions that you have in the chat, but we'll also have time for questions throughout the presentation. Listen with respect and be present. Please pass on, share the learning, spread the word about these sessions, and please be aware we are recording the session as well. So if you've got any colleagues that weren't able to attend, please let them know. I will now pass over to Sue and Louise.
Lovely. Okay, thanks, and lovely to see everybody. So I'm going to take you through the slides, and Louise is going to be on hand for any questions and discussion at the end. Thanks for the opportunity for us to come and on this Connect session. As I say, we're going to just share some of our experiences with you. So first of all, sort of a question you may be asking about, why British Red Cross and Hospital at Home? Well, when we'd recognised that hospital at home services were becoming more prevalent within the NHS, and we'd looked to see what the impact might be on health inequalities and what research there was around, and couldn't really find very much. And our 2030 strategy, one of our key ambitions is around addressing health inequalities. So we were really interested, as virtual wards, hospital at home services are becoming more mainstream, whether there would be an impact on health inequalities either positively or negatively. And because there wasn't really much there, we decided that we would do our own research. So we've been really interested in trying to stimulate discussion and challenge within the hospital at home community about the impact of virtual ward services on the whole population. We've done some research which I'm going to talk to you about today, and then we also recognise that support to hospital at home patients was a really good fit with other services that we do provide. So some of you may be familiar with our support at home service or our assisted discharge service, where we're working with individuals in their own home to really improve their resilience and independence, to stop an admission to hospital or just stop a readmission to hospital. So those services are up and down the country, but we wanted to try out a new hospital at home service, which, as I say, we've done with North Cumbria Integrated Trust, which I can talk about in a moment. But first of all, I just want to run through the two pieces of research that we've done, and then I'll take a pause after that and we can have a little discussion about what we've found, and then I'll go on to talk about the pilot. So our first piece of research was with the VCSE Health and Wellbeing Alliance. So this is a group of 18 different voluntary organisations and people with lived experience of health inequalities. So they weren't necessarily people who'd had experience of a virtual ward, but they had had experience of experiencing health inequalities. And we were looking at the risk, responsibility and opportunity on virtual wards for health inequalities. So, as I say, we did that consultation with clinicians working on virtual wards, people with lived experience of health inequalities, and the organisations that supported them. And we found a really strong consensus that if hospital at home services are set up without a real focus on addressing the barriers to both the access to the ward and people's quality of care whilst they're on the ward, then it can risk widening the inequality gap further for some groups. So therefore, in order to make sure that we realise the potential for hospital at home services to reduce inequality, but also to avoid the unintentional consequences of exacerbating existing inequalities, it's really important that when systems and providers are setting up hospital at home services, they need to develop a really detailed understanding of the barriers that their local populations might face in accessing those services, and then also the quality of care on those services. And they also need to explore whether additional support is needed to help overcome some of those barriers. So first of all, the really good news is that we found that hospital at home services have got the opportunity to reduce inequality and improve care for lots of people. So perhaps people who live far away from their nearest hospital, where getting to the hospital or having visitors while at hospital would be a real problem, hospital at home services can be a really good thing. There might be people who might find a hospital environment really distressing, perhaps people with mental health issues, dementia or learning disabilities, who, for those people, there's a particular benefit in being able to receive care at home and just in the comfort and familiarity of their home environment. Children, again, might benefit. Obviously, it's children's not a scary place to be in hospital, so they're retained in their family environment. People who perhaps have got religious practices that mean that they can honour those more easily at home. People who go to hospital a lot, such as older people where it's a real benefit to be treated at home. And then the last one there, they've got increased risks of hospital-acquired infection or deconditioning while they're in a hospital setting. And finally, people who might be concerned about discrimination or lack of sensitivity in clinical settings. So those are all the really positive reasons why people might want to stay at home, and we can really help inequality for those. But there's also issues around potential health inequalities. So the quality of care at home can be affected by a range of different factors. Some of those are deprivation linked. So, for example, the ability to prepare good food when they're at home and maintain necessary levels of nutrition for recovery, and also lack of support for unpaid carers. Some are communication linked. So perhaps if their first language isn't English, their literacy levels are poor, and they really have difficulties reading instructions, then actually doing some of the self-care that they need to do while they're at home on a virtual ward might be quite difficult. And then there's also things like health literacy, their ability to manage their own health, confidence using technology, people who live alone, a small social circle. It can be quite isolating being cared for at home. And we found that although there are barriers to access, there's no national data identifying which people decline the offer of a hospital at home and why. So we know who goes on, and we can look at the population on a ward, but we don't know who's not been offered it or who's turned down that offer. But there might be a number of barriers, such as a poor home environment, lack of access to additional personal and social care, worry about burden on family members or other unpaid carers, and then other additional complex physical or mental needs, and then also fear of strangers entering the home. So those are all factors that can affect the quality of care. So what we tried to do, taking all that on board and trying to offer something back to the NHS, was looking at what steps people could take, sort of practical steps that we could offer to clinical leaders, frontline managers, to start and help thinking about some of those barriers to access, but also the use of services. And if you look at the report, these are in a lot more detail, but I just go through those 6 key steps. So the first one is understanding who are you offering these services to. So is the population, that on your ward, is it does it mirror the population that you have in your, the demographic within your local area? Just to make sure that you are offering services to everybody. Obviously there are clinical criteria, but beyond the clinical criteria, who are you offering services to? The next thing then is in order to provide the right quality of care within those services and reduce some of those barriers, what elements might you need to include in the design of your service that will maximise that accessibility and quality of care? So that's around doing that sort of holistic needs assessment for individuals, including the home environment, falls, safeguarding, but also just challenging who's actually being offered the ward beyond the clinical barriers, other people who could be offered with some additional support. The third step is really thinking about how you communicate what that virtual ward or hospital at home service is. So there's lots of, even just the terms, I keep interchangeably using virtual wards and hospital at home because they're both still being used. We had thought when the latest framework came out, there would be more of a direction to be calling it hospital at home services, but virtual ward terms still being used. So just thinking about really ensuring that people understand what that service is, to allay any fears, and making sure that that communication is clear to both individuals and carers, and thinking about people's additional communication needs when you do that. The fourth point is about thinking about diversifying the skill mix. So making sure that your staff have got the training to do that holistic needs assessment and think about the person's home setting and other factors that might be barriers to them having a really good experience. But also thinking about partnering with other services to deliver some of that non-clinical support, if that's felt to be appropriate. Then it's around offering choice to people. So recognising that people have got really individual needs. So that holistic needs assessment can really think about what those choices might be for people, thinking about the support for and the choices for unpaid carers too, and really think about discussing people's preferences for professionals who are coming into their home, just making sure that they're easily identifiable, they've got methods of identification, and that there's a really personalised care plan that acknowledges that that care has been provided in somebody's own environment, which is very different from being caring for somebody within the confines of the hospital. And then finally, collecting data. So collecting really good data so you can understand who is being included in your virtual ward and who's being excluded, so that you can make sure that you're really trying to provide as equitable a service as possible. So the full report is available on that link. I'm sure the slides will be shared after, and you can read the full report. As I say, there's a lot more detail within that report. So I'll go straight on to this next piece, and then we can discuss both of them in a little bit more detail. So the second piece of research was done with Cheshire and Merseyside ICB and a virtual ward. It was a acute respiratory infection virtual ward in Cheshire and Merseyside. So on here we were looking at who was included and excluded from that ward. And we found that the following groups were likely to be more included or excluded on a sort of sliding scale, really. So the most included were, as you might expect, younger patients and older patients with family support. And that sort of ranged through to the least excluded being those with disabilities, dementia, and other conditions. But we found that there were varying reasons for people being excluded. So as you'd expect, people were excluded because they didn't meet the clinical criteria. So we call that exclusion by design. But we also found that people were being excluded because of clinicians or people's assumptions and perceptions about a patient and their ability to cope within that hospital at home environment. And we call that exclusion by bias. And we found that that exclusion was exacerbated when the pressure was highest for NHS staff. So I suppose that sort of stands to reason in some way that if you know that somebody's got additional needs and you haven't got the time to identify those and meet them, then they're perhaps were less likely to be offered a place on the virtual ward. So what we then did was take that research and we took the UK Government Digital Inclusion Scale to look at creating some personas. And we wanted to do that to really help us understand who we're designing services for and what their needs are. And we came up with 3 different personas. And, maybe when I'm talking through these, you could think about your own experience on your own wards and think about whether you can identify people that you may have found on your ward like this. So the first one are connected homesters. They've all got slightly funny names. So these are patients who want to benefit from hospital at home and they're really keen to avoid going into hospital or they want to get home sooner. They may have some limited technical ability, but what they have got is often got support at home, which is why we call them connected. So for them, oh, that's a funny noise. They've got limited barriers to access, but they do rely quite heavily on family. So that can be quite hard when families have got competing commitments. And this group might be reluctant to go into hospital even if unwell. So they might be the ones who are saying that they really can cope when perhaps they can't because they really don't want to go in. So there's a quote there as an example. I started coughing up blood and let them know on the kit, but there's no way I'm going into hospital. So that's the first group. The second group we called solo beginners. So this group is really health anxious and they see hospital at home as an opportunity for closer monitoring. They might have mobility challenges due to their condition, and they've probably got limited support in place, and they often live alone with limited social interaction. So for this group, these are the ones that clinicians might be reluctant to refer due to the lack of support at home. And that social isolation might mean that they really value the support from the hospital at home service, but it can be quite challenging for the team because they can be quite demanding on their time. So they like phone calls back, they like people coming out because they like that reassurance that gives them. So that's for this group, an example quote might be the kit didn't work, but I preferred that as I got daily phone calls. So they just like that extra support. And then the final group are the excluded resistors. So this group is really uneasy about the digital health monitoring. They don't have much capability or opportunity or the motivation to engage at home, and they're really not used to managing their condition. So it's this group where we found that there's most assumptions and bias preventing admission to a hospital at home if it's offered at all. And staff aren't always really sure what they need, what services they could or should signpost them to in order for them to access the ward. But even so, because they're quite anxious group, they even if they're offered without support, they're likely to decline a place on the ward. So the quote from them, don't want to see that kit, I'm really not interested. So what we then did was looked at those personas and looked at where there were opportunities along the care pathway to provide additional support that might help them. We provide both equity of access, but also equity of experience. So the first group, the connected homesters, it's about spending more time with the patients and their family members on the benefits of the ward to encourage consistent engagement with the ward staff to avoid those readmissions. And then also understanding family commitments and what else might be going on, just to make sure that the family's being properly supported as well. For solo beginners, it's about combining the set kit up and support with daily support at home activities. So we're trying to just reduce the demand on the clinical staff by providing that reassurance, but also signposting to additional support that might already exist within your community. So loneliness support, perhaps a befriending service, getting them interested in and knowledgeable about social activities that might be available, and long-term health monitoring, just to improve their own feelings of confidence in managing their own conditions. And finally, the excluded resistor. For this group, it's about challenging assumptions and bias by working out what they need to support them, and then providing reassurance to the referrers that with that additional support, those people can cope within their home setting. And although the most effort needs to go into that group, it's really important that we don't forget this group, because that's where we'll see the most exacerbation of health inequalities. So the research, which had been looking at the use of a digital buddy, found that a digital buddy would increase access for those currently excluded, but really the digital buddy solution will only increase access where persons' barrier to access was purely digital. Patients who've got additional support needs will need a more holistic solution, and therefore providing a bit more holistic support would enable more successful hospital at home referrals. So I'll just pause there from the sort of research perspective, and I just posed a few questions. I'll take this slide off in a minute, but just whether you could recognise any of those personas in your own patient cohort, and whether you feel your virtual ward, hospital at home service provides or has those measures in place to address the equity of access to your service. And then once they're on there, is everybody having a similar patient experience by virtue of the right sort of support and environment to have a really good recovery? And then also patient outcomes. And those 6 steps that I've talked about, do they seem doable? So I'll take it off because it's nicer to see each other's faces. So I'll stop presenting for now and just hand over to you, really, if you've got any reflections. I don't know whether you want to chair this little bit, Ashley, but
I'm more than happy to.
So yeah, if anybody's got any questions. Anybody on a ward, could anybody recognise any of those personas in your own population? We got anybody here who actually works on a ward, or is everybody on commissioning side? Do we have any providers? No, all commissioners. Oh, Lorraine. Hi, Lorraine.
Hi, sorry, I've knocked my background off because there's something going on behind me, so I apologise if you're picking up the noise as well. So I work for Hospice at Home, West Cumbria. So thank you, Sue. I think personally we have a support at home service as well, which is predominantly aimed at those at end of life, so they fit within the fast track eligibility. So I'm just a question around, obviously, those individuals who the virtual wards are supporting and the signposting. Is there a mechanism that feeds into hospices? I'm not entirely sure where those who are palliative and are at end of life with these obviously longer term chronic comorbidities fit within your respiratory model. We have referrals from the respiratory team. I'm not entirely sure where we sit within your virtual ward, etc. at this moment in time.
Louise, do you want to take that up as a practical question?
Yeah. Hiya, Lorraine. At the minute, so we've been operating the service now for over a year. And so far, all of the patients that we're supporting are patients that are either residing in their own home or are in residential care, because we support the residential care homes, etc., nursing homes, with showing them how the observational kit works. But at the moment, we're not supporting anybody end of life or palliative care, where we would then be either referring on to.
And I know that sort of nationally we've had some discussions with Marie Curie around, we're just recognizing that a lot of people in a virtual ward are on an end of life pathway. So it could be, Louise, I'm sure that some of the patients that you're caring for are on an end of life pathway, but I suppose you've not had any direct contact with the hospices.
No, and I think as well, because of the first year of the service being a pilot, it was so that was kind of the start of the modelling on virtual wards. There was that bit of lead-in time to actually get that kind of throughput of patients, and so far we've mainly been working with respiratory and frailty, and that seems to be sort of the main focus point at the moment. But then heart failure will be coming on as that third practice patients a bit further down the line. And I think that's probably quite prevalent across most of the virtual wards at the moment.
I wonder, outside this meeting, there is something that we perhaps can pick up on for, maybe future consideration, or even just tapping in slightly to some of the things that you may be coming across, Louise, in that kind of collaborative support, etc., and signposting. I'd absolutely be more than happy to do that if you feel that's an opportunity worth, obviously, just even, an hour, half an hour externally. Sorry, people on the meeting.
That would be great.
Yeah, I've just put my email address in the chat.
Yeah.
I think this is called Connect and Learn.
Yeah.
Connections. That is exactly what we're here for.
Thank you.
Anybody else? Can anybody else have any reflections on that research? You're a quiet bunch, aren't you? Anne-Marie.
Yeah, I'll just, hiya. I work in primary care. Can't really comment on a lot of the kind of setup of virtual wards, but I do recognise those kind of sets of patients in primary care as well. So I think you see them no matter which kind of sector you're working in, and people feel differently about healthcare, don't they? So, yeah.
Good. Shall I move on to the pilot then, if we don't? So let me go back to my slides, and you'll just have to I'll have to well, 1 second. Right, okay, share presenting teams. I'll have to just whiz through them again. Right, okay. Okay, I just thought it would be worth just going through quickly the virtual wards operational framework that NHS England published in August this year, just because there is some elements there around tackling health inequalities and also that holistic assessment. So I suppose there's lots of things in the framework around the benefits of hospital at home now being really well evaluated. So showing that they can be cost effective and more productive. They give improved patient experience and choice, improved patient outcomes and protection from avoidable harm, and improved staff experience. So as I say, we just want to make sure that those benefits are available to everyone, or as many people as possible, especially as services are scaled up. So the framework does provide guidelines for assessment of patients' holistic needs. So it suggests that should be undertaken by or jointly within the transfer hub. so that virtual ward care is adapted to the individual needs and patients' individual circumstances. That assessment should include a home environmental assessment, falls risk assessment and safeguarding. So you can see how this sort of research has been influencing our research has been influencing this guidance. And then the assessment and the needs of the carers should be undertaken. So I think there's a real growing realisation that people on a hospital at home, we're creating a sort of, it might only be a short-term carer for the days that they're acutely ill at home, but it still meets the definition of a carer. And obviously organisations have got a duty to look out for the needs of carers. So there's a requirement for services to support patients, carers and care home staff with the use of technology and offer alternatives to prevent digital exclusion. Health inequalities measures should be embedded to enable equitable access, experience and outcomes. There's a section on developing partnerships with local communities, so to just make sure there's that diverse skill mix, and also mention about the funding of non-NHS organisations or staff who are being expected to provide that support. And then in the appendix, there's more detail about support to carers. So that's about identifying unpaid carers, signposting carers to carer assessments. There's a lot around, and Carers UK have done some work. If you've not already seen the Carers UK checklist, there's a really nice checklist that Carers UK have done, which just really empowers the carer to be an equal, an expert partner in the care if they're caring for people at home. So it's really just empowering those carers when they're caring for somebody on a virtual ward, so that they've got a better understanding of what the service is and what their role in that is. So that's the sort of the framework is putting our research really and other factors into practice. And I just want to spend some time now talking about the Cumbria pilot. So we started the pilot in July 23. We didn't get going for some time just because the ward was new, and it took quite time to get the ward set up. So we did lots of work helping get the ward set up. The pilot officially finished in June, but we're still providing that service up in North Cumbria out of Wigton Hospital. And as Ashley mentioned in the introduction, it's funded by North East and North Cumbria ICB. So our support workers are an integral part of the North Cumbria Hospital Home team, and patients' needs are assessed to facilitate admission to the ward and then to improve their experience of hospital at home care. And we're there really to offer practical and emotional support to meet those needs that have been identified, including training and support with digital health monitoring. So I'm sure you can imagine that, when people are in hospital, we just take it as read that people are being fed, that they're in a clean bed, that they've got clean clothes to wear, that they've got food that's going to, help aid their recovery. And obviously people have arrived in hospital or are being avoided being in hospital in very different circumstances. So for somebody going into a step down virtual ward where they've been admitted to hospital and then going home early, they might have been admitted in an emergency, they might have left a soiled bed, they might have the bin overflowing, no food in the fridge, and it's really not an environment very conducive to a good recovery. So our staff can do that home assessment and provide that additional support. So we can do, light housework, we can clean the bed, we can put the washing on, we can make sure they've got clean clothes, we can make sure they've got the prescription, empty the bins, fill the fridge, etc. And we provide that support for 0 to 4 weeks. So obviously that support can extend beyond the stay in the ward. And that might be because we're doing extra signposting or recognising that we can meet some of those needs that will build that resilience and independence in that person to reduce the chance of readmission to hospital. So why British Red Cross involvement, or the involvement of any third sector organisation really, there's a number of different factors that we've recognised through doing the pilot. So the first is around improving equity of access. So that's reducing some of those non-clinical barriers to admission. So for example, people who might be living alone without that additional support, people who've got low levels of literacy, so find it difficult to understand instructions, people who've got low health literacy, so really underconfident about managing their own conditions. We can provide that additional support to help them. The second one is around improving equity of patient experience and outcomes. So once they've got on the ward, that additional face-to-face contact, or even contact on the phone, we can offer that practical and emotional support and signposting to other support that's available in the community to help them. Reducing digital exclusion. Obviously, not every patient on a hospital at home service has got digital monitoring equipment, and lots of people are obviously able to manage that themselves, but a lot of people just need that additional support. They might have had the digital support and the digital equipment explained to them when they were in hospital. It's a different, once they get home and it's a different environment. They were perhaps, anxious or not feeling well when they had it explained. So that additional support can really help them make the most of that equipment and make sure that those digital monitoring readings are available to the hospital at home team to ensure that really good clinical outcomes. But we can also support on more, wider digital inclusion support. So perhaps getting them online, sorted online shopping, repeat prescriptions, downloading the NHS app, so for themselves or their carer, just making sure that they've got the digital support that could really help their independence. And finally, addressing the burden on carers, so making sure that their needs are being assessed and providing perhaps some short-term respite care, just enabling them to get out and do some shopping or go and have their hair cut or meet a friend for a coffee that will help them, again, improve the sort of resilience of that stay. So all those factors are then helping us improve the sort of system. So we believe we can help improve patient flow by reducing barriers to admission. We can improve ward occupancy. Saving clinical staff time means that clinical staff time can be spent with those who need it most, and then we can again sort of improve occupancy by maximising that clinical time. And by really focusing on activities that improve independence, we're reducing the chance of readmission to hospital. So those are some of the real sort of benefits of addressing those factors. When we look at some of the outcomes, we supported 41% of the people that we support within North Cumbria lived alone. At the beginning of the pilot, the clinical staff were really quite reticent to refer anybody who didn't live with additional support. And we found that of those we supported and gave feedback, 70% felt better able to manage their own health. They were less anxious, less lonely, and they were more aware of other support that was available for when they needed it. So we're still learning. It was a pilot. We've had a little bit of the clinical lead has just been reappointed at the moment. So it's been quite sort of different time on the ward, but we've the thing that we've really learned is the needs to be continue to be flexible to the needs of the team. As the ward was new, it was developing, so we've had to shift around the tasks that were needed, the way that we provided the service, and we want to look at a scope of practice, whether there'd be value in it being a regulated service so that we could provide some personal care, which we don't do at the moment, and also looking at the hours of practice. The research is now in, so we want to do some more work looking at the barriers to virtual ward patients so that we can really build the confidence of staff referring in to make sure that we're referring in as many people as possible. We're looking to introduce a more formal assessment of carers' needs. and making sure that we're really focusing on those activities and goals that will improve people's independence and sustainability. And then also look at mechanisms that we can put in place to try and work out the social value of that support and the return on investment to assist service commissioning. And just always making sure that we're proactively reviewing the services and adapting to ensure the best possible practice. So I will go back to stop sharing and just happy to take any questions. Thanks very much. Any reflections?
Lorraine's got
Lorraine, yeah.
Hi, Sue. Can you, I'm just interested in your outcome measures. Do you use a specific tool, or is it something that you've devised yourself to identify, obviously, the improvement, obviously, with those individuals?
Yeah, so we've not introduced it yet, but across the Red Cross, we have introduced Ascot. So we will be considering the use of Ascot. We've got Ascot with a couple of additional domains for finance, and which is the other domain, Louise, on the, there's a finance domain, is it a loneliness? Not anyway, it's Ascot quality of life as a sort of outcome domain. And then we've got our own, Louise, do you want to just talk through the BRM and the data that we collect on our BRM system?
Yeah. So yeah, the BRM kind of aligns itself with the kind of holistic assessment that we do. So that's all around, so the kind of data that we capture on there is around home environment, finances, health, well-being, comorbidities. It's all kind of general stuff that I guess probably a lot of people will kind of will capture, and then we capture quite I can't get the words out, comprehensive set of EDI data as well. But as Sue pointed out, yeah, we're mainly using Ascot within this service. We also, I don't know if you've heard of SwemWebs, which is the Warwick and Edinburgh wellbeing scaling. We use that, but that in other services.
Yeah, I'm familiar with the Warwick and Edinburgh wellbeing, but thank you. That's really helpful.
Any other reflections? No? You might be gaining some time back. Oh, Rachel.
This is a bit of a random question, but I used to work in the community and acute, and one of the barriers for people accessing healthcare was around their pets and people being available to look after their pets. Do you link in with any of the local animal charities in terms of supporting patients to stay at home? And it's one of their concerns.
Yeah, that I'm aware of that we do. I'm not kind of at the granular level on the front face of service delivery, but yeah, in them kind of situations, we will help out and signpost and support, and we have done.
Yeah, lovely. Thank you.
Any further comments or reflections? Anyone?
I've put my email address in the chat, so if anybody kind of like afterwards has a bit of a think, or might be interested in sort of like more of the detail of the actual service and how that operates, then I'm happy for anybody to get in touch.
Brilliant. Thank you, Louise. And thank you to you as well, Sue, for coming along and sharing your experiences. We really do appreciate it. So we'll have obviously a copy of this recording available on the Boost website. And Sue and Louise also kindly shared with us some kind of like further case studies. So it goes into obviously a bit more depth than what you've heard today. So we'll also have those available with the recording on the website as well. So if you want to find out any more, please feel free to have a read, and obviously, as Louise kindly offered there, please get in touch with them if you'd like to follow up at all. Brilliant. Well, thank you again, Sue and Louise.
Yeah, it's a pleasure.
Thank you.
Thank you so much, everybody, for attending, and hopefully see you on another session soon. Take care, everybody.
Lovely. Thank you.
Thank you.
Bye.
Bye.
Thank
Bye.
you. Take care.